This is one day I just happened to go online and see this ad about Inspire, and I thought, oh my gosh, I need to look into this. Maybe this is the answer.
I was like, wow, look at this. And so I immediately went online and I read all about it. I called up that day and made an appointment.
The more I read, the more excited I got. And instead of feeling defeated, I felt hope that there was something there that was actually going to work.
I was inspired to hear that there was something other than a CPAP machine and oral appliance, because those were the only two options that I knew of.
I had tried all these other things, and it was at a point of, I don't know what I'm going to do.
I felt like I had been in pain for years, living with a CPAP, with a dry mouth, with it irritating my skin. I just thought, this is the end all. I'm totally excited about it. I want to get it. Life is going to be fantastic. I had no doubts.
I had no apprehensions. I knew it was a new product and everything, but I knew what I had been dealing with over this period of time. To me, it was not really much of a risk. It was just something that I needed to try for myself, to try to get some peace of mind and some more rest.
Once I met the Inspire team, they helped me with my insurance. They were behind me 100%, as my doctor was. My family was extremely supportive.
I got in touch with Amy from Inspire, who reached out. The way she talked to me, the questions she asked, you could feel she had a passion for it. It made me feel good that, okay, here's somebody who's really on this. She believes in it. I would highly recommend contacting anybody at Inspire. If you've got any questions, if you're unsure about something, just talking to somebody about the experience or what they could go through, or just to get those answers, is well worth it.
This little device here is the brains for the Inspire implant.
You put it up on your chest, hit the little green button, and it'll turn itself on. Once I wake up in the morning, it's the same thing. I get a little power button, put it right back up on the chest, and it turns itself off.
And you can have that set when you get it customized for how long you want it to take for you to fall asleep. I chose 40 minutes so that I have enough time to read or do whatever I want to before it turns on.
When they first put that little device on and they're starting to turn it on and activate it, and I remember Ann telling me, okay, let me know when you feel something. And then just out of nowhere, your tongue juts out. And she's like, okay, we've got our baseline. She's like, I'm going to set up the remote. We're going to send you home, and I want you to use it tonight.
I turned it on, and my tongue went a little forward, which it didn't feel like anything at all. It was just a very gentle movement, and I fell right to sleep. I have this on my night table, and so I just grab it, click it on, put it on my nightstand, and go to bed. And then when I wake up in the morning, I turn it off. And if you have to get up in the middle of the night for some reason, there's a pause button.
Just turn it on, go to sleep, and wake up in the morning and turn it back off and go on with my day.
There's no mask. There's no device to put in your mouth. There's no machine that you have to clean.
For 14 years, this is what I actually slept with. Now, this is what I sleep with.
There's no way I would ever go back to using a CPAP or even attempt it, because this has changed my life.
All right. Well, my name is Brad. I work for Inspire, and I want to welcome everybody to our presentation this evening. Dr. Trott and Dr. Malish and Shauna, if you guys would be kind enough to go ahead and unmute your screens as well, so you can participate now in the discussion. For everybody on this evening, you guys are in for a treat, as you guys have your sleep medicine team from Jackson, Wyoming, here to present this evening. We've got Dr. Trott, Dr. Marty Trott, who received his undergraduate and medical degrees from the University of Rochester with honors, and then trained at the Cleveland Clinic. He also received his Master of Medical Management at Carnegie Mellon University and is the medical director for St. John's Health. Dr. Malish is dual board certified in both sleep medicine and pulmonary disease. Dr. Malish completed fellowships in both pulmonary and critical care at the University of Southern California in sleep medicine and from the Mayo School of Graduate Medical Education. We also have Shauna Giles, who is our nurse practitioner. She's a staple there at the sleep medicine facility at St. John's. Many of you may have already met Shauna or see her. She holds a bachelor degree in nursing science from the University of Pittsburgh and a master's degree in nursing from the University of South Florida. So you guys are in great hands tonight, and I'm looking forward to a wonderful presentation with our providers. I'm going to run through some slides quickly here. Let's see. Here we go. Just want to let everybody know that the meeting is being recorded. If you want to ask a question, there is a Q&A icon in the bottom of your screen. We will have some time for questions at the end of our presentation. I will make sure and try and moderate all those questions and get all your questions answered if time permits. To answer a question, you can simply hit the Q&A icon, which is right there. Type in your question, and it will be submitted to me as the moderator. So with that being said, thank you all for being here. Ask your questions if you have any, and I'll let Dr. Trott, Dr. Malish, and Shauna kick off our event this evening.
Okay, so can everyone hear me? Can you hear me, Brad? There.
Absolutely, you sound great, Dr. Malish.
Okay, good. So I'm Dr. Malish. I'm one of the I'm the pulmonologist here in Jackson at St. John's Health, and I practice sleep medicine as well as pulmonology here. I'll be giving the first portion of the slides, followed by Dr. Trott, and then Shauna will be giving the last portion. And just to start off on this first slide, it is a representation of what happens during an obstructive sleep apnea event. And in its most basic sense, it's a collapse of the airway, which is illustrated here. You can see should be able to see two purple airflow arrows, which should be in a usual patient going all the way down to the back of the throat, into the airway, down into the lungs. But you can see those arrows stop at various points. On the left-sided arrow stops in the back of the throat, where there's collapse during an apnea event. And then the smaller arrow actually stops in the location a little further to the right or more towards the patient's feet. But it really the point is it really doesn't matter where the airflow stoppage happens. Anywhere along the airway can cause a problem. So like in the nose with like sinus congestion, soft palate, which you see here, or further down if weight's an issue when you have a larger neck, it can happen there too. And so this is an important problem. It's very prevalent in the population. There's over 20 million Americans that have at least moderate to severe obstructive sleep apnea. And this is an illustration of that. Next slide. Can we go to the next slide? There we go. So this is some additional information. During these events where there's collapse of the throat in cessation of airflow, and that's where apnea actually stands for cessation of airflow. It happens during sleep, which is where the sleep comes in, and then obstructive is because it's an obstruction in the airway. So that's where obstructive sleep apnea comes from. During the obstructions, you can see this graph. It's a little bit small, but there's good oxygen saturation that starts out fairly high in that white zone all the way to the left. And then when there's an apnea, then you can see that gradually decreases all the way down 47 seconds later to 84%. And then there's a recovery where the airway opens up, and then saturation increases again. And then there's a longer apnea on the second portion of that graph there, and it falls even further down to 74%. Next slide. Okay, so this usually manifests itself in various presentations for different patients. Some patients get only 1 or 2 symptoms. Others get a whole array, but the common symptoms would be daytime sleepiness, the productivity or executive function sometimes is affected and noticeable by both the patient and other people. There's a big public safety push for obstructive sleep apnea because it was a cause of car accidents, and especially in they're finding long haul truck drivers. So that's not good. And so there's a lot more regulation in that regard with that industry. But regardless of who you are, you don't want to be sleepy and fall asleep at the wheel and get into a crash. It can affect the bed partner because if you're having noisy breathing at night, whether it's snoring or sleep apnea, it can affect your bed partner, and then neither of you get a good night's sleep. And then further down the line, if your heart and lungs aren't able to rest how they should at night because they're struggling with this low oxygen issue from the apneas, then it can essentially lead down a pathway to higher arrhythmias like atrial fibrillation and even stroke and heart attack. So next slide. So the way that the gold standard for treatment of sleep apnea for obstructive sleep apnea is CPAP, which stands for continuous positive airway pressure. It's great when it works, and how it usually works. How it works is that it blows in some gentle pressure into the airway to keep everything nice and open, and it works some of the time, and it works great for a lot of people when it's able to be tolerated by the patient and when it actually can clear up the apneas. But that's not always the case. A lot of times the patients can't get used to it. They're claustrophobic. The CPAP can cause other sets of issues that make the treatment seem worse than the disease. And so a lot of patients just can't tolerate it. And that's where we look into other treatment options. So next slide. Okay. And so I think I'll let Dr. Trott take over this portion because it gets into some of the treatments options such as Inspire.
Thanks, Haven. And if you guys have any questions at the end, we're all going to be here. So just submit your questions to Brad through that little button. There are many management options for sleep apnea other than CPAP, although I agree with Dr. Malish that CPAP is the way to go, and that's what I encourage patients to do. And patients, we kind of divide sleep apnea into kind of the mild, medium, and hot form, or moderate, severe, or mild sleep apnea. And patients with very mild apnea, sometimes we can get away with these things that are shown in the upper right-hand picture that looks like sort of 2 dentures or retainers stuck together. These are appliances that pull the jaw forward, the lower jaw forward. And by pulling the lower jaw forward, we're pulling the tongue forward, and that in some patients can be very helpful. It can also cause problems with the TMJ, and some patients love them, and it doesn't work for everybody. And then there's a lot of anatomy altering surgery, things like tonsillectomy, or if you've ever looked online, there's fancy words like UPPP, which are acronyms for surgical procedures, essentially where we're doing something in the throat to remove soft tissue. And in my experience, those were historically the only options that we had. But we're trying these days to do something that is not fixing the problem with something that's fixed, that only occurs during the day and night. We want to do something that occurs only during sleep. And that's the advantage of Inspire. Let's go to the next slide. So Inspire is an implantable device. It sort of looks like a pacemaker. That's what it looks like on the left. It's implanted under the skin through 3 different incisions. The operation takes between 2 and 3 hours, and it's done with you asleep in an outpatient surgical center. You don't need to stay overnight in the hospital. There are 3 incisions, one under the jaw, just to the right of the midline, one in the chest, and then another one where we implant a wire that allows us to determine when you're making a respiratory effort or when you're trying to breathe at night. That's when the obstructions occur. It's off all day long. And just like this is shown here on the right, before you go to sleep, you activate the device, and we set a latency, work with Shauna, to set a period of time after you turn the device on before it starts working. because some people can feel a small activation, or it's not like a shock, but they can feel that their tongue is moving. So a lot of times people want to fall asleep first. We set it for 20 or 30 minutes. Go ahead, Brad, you can hit the next. So this is how it works. This is someone going to bed at night, where they grab this device off the bedside stand and just touch it next to their sensor. And then what happens is the device has an activation or pickup lead, which senses breathing, shown to the right. And as you take a breath, that transmits information to the tongue area, showing the breath through this central portion on the chest. So it's electrical, essentially a battery device that stimulates the tongue to move forward during a respiratory effort or a breath. And it cycles. So every time you take a breath, the tongue moves forward. And if you're not taking a breath, the tongue doesn't move at all. And the operations used to implant this device onto the nerve, where we just use the part of the nerve that allows the tongue to move forward, because as you know, your tongue goes forward and backwards and sideways, and we identify the nerve that moves the tongue forward. Go to the next slide. So this, as I mentioned, is inserted through incisions that are done during an operation. And all of the patients I've done, I have 2 more next week, no one has needed to even like Vicodin. They've gotten away with Tylenol or Motrin. I've asked patients not to do really strenuous activity like throwing baseballs or inverted handstands for the first few days. And we typically arrange for patients to be seen by Shauna and Dr. Malish about 30 days after it's implanted. I see people, if they're coming from a distance by Zoom, at 7 to 10 days after surgery. And then we see them for activation live, where we teach you how to use your device. The device has 11-year roughly battery life, and MRIs can be used pretty much everywhere except in the heart and shoulders. So one of the big concerns that we had initially is whether this would be compatible, but we want to make sure that patients can get MRI scans of their brain if they need them, looking for things like stroke. In the event that that were to ever happen, it's perfectly safe to use in that situation. Next slide. So what I'm gonna do is I'll turn it over to Shauna, who is actually would be the person, and I've been to the activations as well, but Shauna, why don't you describe what we do after it's been implanted and patients gone through the minimal recovery.
Thanks, Dr. Trott. I'm Shauna. I'm the nurse practitioner here at the Sleep Center at St. John's. So you'll come see me about 30 days after your Inspire device is implanted for that first visit where we're gonna activate your device. At this visit, we will establish those effective and comfortable settings for you, and also show you how you're able to use the remote to self-titrate therapy within a range that we set for you, as well as set those parameters like the latency to sleep, and show you, kind of what to expect going forward. We ask you in the next few months to self-step up your therapy with that remote so that you can become more comfortable and used to Inspire as it slowly, gradually increases. And then we bring you back into the sleep lab to do a titration study where we're going to define that optimal level of therapy for you. So you can just see here in the video, the remote that you get, there's a comprehensive booklet. We'll go over all the different things that you need to know so that you can manage therapy at home. You can go to the next slide. So the biggest question I get is, does it work? I've had a lot of patients who have been on CPAP and failed CPAP. It didn't work for them. And really, the studies show that Inspire is very effective. This slide points out that the average apnea-hypopnea index, or AHI, you can think about that as respiratory events per hour of sleep. In patients in this study prior to Inspire, the average was 29.3, which is quite significant. After Inspire, that was reduced to 6.2 times per hour. So that's a 79% reduction. And that really shows that it is working for people. You can go to the next slide. We also see that snoring is significantly reduced, about 88% reduction in snoring reported by the bed partner with Inspire therapy. So it can help benefit everybody in the bedroom, not just the patient with sleep apnea, but can also make things a lot quieter. Can go to the next slide. And a big thing for me is that patients actually like it. We see a 94% positive feedback with Inspire. I would like to say CPAP, you know, is well liked, but it's unfortunately not. And that's also demonstrated by the average time that people are using their Inspire therapy. We see almost 6 hours of nightly use in patients with Inspire. The Medicare and insurance standard requirement for CPAP is 4 hours, and that can be a struggle for many people to even reach that 4-hour mark. So when I see these higher numbers in Inspire, that's really promising as well. Next slide, please. There are a plethora of peer-reviewed trials, over 100 publications, and long-term follow-up as well with the 5-year STAR trial. So the research is really supporting this as an alternative treatment to sleep apnea, and we're seeing that insurances are acknowledging that as well, and most U.S. insurance companies are now covering Inspire, and that does include Medicare and most of the VA and government insurance plans. Next slide, please. So there is some qualification criteria to qualify for Inspire. The first is that we want to see that obstructive sleep apnea is to at least moderate to severe degree. So that is an AHI or an apnea-hypopnea index between 15 to 65. This we like to see on a sleep study. Most insurances require that study is within 2 to 3 years. So if your study is older than that, just be aware that we may need to start baseline and get a new sleep study to get the process rolling. We also have to document that patients aren't getting consistent benefit with CPAP, whether that is because they can't tolerate the pressure or they're claustrophobic from the mask, but for whatever reason, they've trialed CPAP and it's not working for them. We also need a BMI less than 32 for most insurance companies. For Medicare, a BMI less than 35 qualifies. You also need to pass an upper airway exam that Dr. Trott does to evaluate that your airway is collapsing in a manner that is consistent with the way Inspire can treat obstructive sleep apnea. And the minimum age requirement for Inspire is 22. Next slide, please. Inspire Sleep is a website that you can go to for reference. It has a lot of useful tools and tutorials, and even a patient ambassador program. So if you are interested and want to learn more, I would encourage you guys to check that out after this presentation. Next slide, please. You can also call our office to schedule an appointment and visit the website stjohnshealth.inspiresleep for more resources. Next slide, please. A common question I get too is, is this something that I should be doing at St. John's, or should I be looking at larger university settings for this type of surgery? And, we have nothing but good things to say about our entire sleep team. Dr. Trott, Dr. Malish, you're in excellent hands. So, you get really personalized care here. I know Dr. Trott gives out his personal cell phone number to any surgical patients of his. So that's something you're probably not going to see anywhere else. Next slide, please. The Inspire Sleep app is also another great resource for you. Again, there's videos, there's tutorials, some common questions that are answered for you. So you can download that from any smartphone if you're interested. Next slide, please. And I think that's the end of this part of the presentation. So I'll hand it back over to Brad.
Hey, thank you, Shauna. Thank you, Dr. Malish, and thank you, Dr. Trott. So I've got 5 or 6 questions right off the bat that I'd like to send your way. And I think this first one is for Dr. Malish or for Shauna. Will Inspire treat a component of central sleep apnea? If you guys can weigh in on that.
I can take that one.
Okay.
The short answer is no. Now, the criteria does allow for some portion of the patient's sleep disordered breathing or sleep study to show that up to 25%, I think, or it's got to be less than 25% can be central apneas. or central type events. And so as long as it's 75% obstructive, then you can still get the Inspire device. So it's not really designed to treat central sleep apnea, but it is allowed to some degree in small portion to be a candidate for the device.
Thank you, Dr. Malish. This one's for Dr. Trott. What is the airway exam and is it invasive?
Well, that's a good question. I mean, I would say that the airway exam, I divide them into two parts. So for folks that live close to here, I would see people in the office. For people who live some distance, and since I'm the only person doing this in Montana or Wyoming and the vast majority of Idaho, we're seeing people by Zoom initially. The next part of so we do it initially an office visit or a Zoom visit. That would be the office visit. Make sure, my staff would make sure that you have the appropriate sleep studies already completed, that you meet the appropriate criteria based on weight/height, the total BMI, and that we get you going to the right place to start with. Sometimes people call and they've got 5-year-old sleep studies, and we'll direct them to Shauna and Dr. Malish instead of to my office because surgery is not the first place to go. And if people haven't really tried CPAP, they really need to try CPAP. Ultimately, the airway exam is done under anesthesia. So there's a two-part procedure. One is the implant of the actual device, which is the surgery, which is the thing that takes 2 to 3 hours. There's also a 5-minute procedure, which is called a sedated endoscopy. And that's very similar if you've ever had a colonoscopy, not the prep, of course, but the type of sleep that we induce. You want to make sure that the airway collapses in a way that's amenable to the fix that Inspire produces. So we give people sedation through their IV and look through the nose and look at the way the palate collapses. The vast majority of people pass that, but there are a few people that instead of collapsing sort of front to back, they collapse like a ring. If you collapse like a ring, people aren't candidates for the Inspire device off the bat. There are a couple of other studies that have actually been done looking at ways we can fix that. But the goal is to minimize the number of operations. So the answer is you first have an office visit. The second part is called a sedated endoscopy, and someone would need to drive you for that. That's also covered by insurance. And then the third part would be the implant device, assuming that we were all on the same page, that was the right therapy and something you were interested in pursuing. It's not kind of a Dr. Trott decision. This is a family patient, Dr. Malish, Shauna decision about what's the best way to manage the patient's sleep apnea with the least amount of risks.
Thank you, Dr. Trott. And I'd also remind everybody, if you do have a question, to go ahead and hit the Q&A icon and type in your question. We will do our best to get it answered. If you raise your hand, we will not call on you and allow you to speak. So please type in your question into the Q&A. The next question I think I can answer pretty briefly. How old can my sleep study be? So with Medicare, the sleep study can be no older than 24 months. That is the most restrictive guidelines. And for commercial, many plans will allow a 3-year-old study or even up to a 4-year-old sleep study. But if you have Medicare, it's 2 years, no older than 2 years. And then commercial plans vary, typically 3 or 4 years. The next question.
Let me chime in there. Brad, let me chime in. And folks that don't have that sleep study, it's not that we necessarily need to bring you into the lab for one of those overnight sleep studies. They can be done from home, and a home sleep study would suffice to make up that difference between the 2 or 3-year-old study. And I think Sean has had some experience with this where patients have qualified. We can even determine if you've had central apnea from those.
Excellent. Next question. Can someone describe what it feels like?
I can only describe what my patients tell me. I've had no one say that they don't like it. Our first patient that when we turned on Bob's device, I actually thought somehow the wire pulled off because he didn't feel anything. And so we're looking at his mouth and his tongue's moving. He didn't feel anything at all. And then, as Shauna mentioned, what we try to do is allow you to titrate the device over time to see how much stimulation you can tolerate. Some people can tolerate, they don't feel anything. Other people feel like a tap, but it's not like an electrical shock. That's what I've been told anyway by my patients. Haven, do you have any thoughts about what you've seen?
Well, I carry some experience in a slightly higher volume of patients that I've seen in other locations that have had the device inserted. And so it's it's a sensation of moving the tongue forward, but it's, even if there's that sensation that is maybe getting in the way of restful sleep, there's a lot of variation in the way the stimulation is applied, where I just had one guy 2 weeks ago. He was really struggling to get to that last level 10, and which is where he needed to be, but was okay right up until that point. And we changed the setup of the way the stimulation was being applied, and he immediately, once we did that, he said he didn't feel a thing. So it's variable, but even if there is some stimulation there that's getting in the way of sleep to some degree, these can be modified, and that's where the follow-up is so important. It's not like here's your device, good luck, like an auto CPAP often is the case. But there's a lot that can be done to make these work. I've seen a very good outcome in patient satisfaction in the patients that we have put these in. Most of them, or a lot of them, don't require any troubleshooting because it just works right away. But there is a process to troubleshoot, and it's been very successful from what I've seen.
Thank you, Dr. Malish. And to your point, the device is very customizable. There's about 5 different settings that can be programmed for patient comfort. So that's a great point. Next question, how long is the process, and when do I find out if my insurance will cover it or not?
I can answer that because I've had some experience with that. I would say that the first thing is making sure that we've got all of the pieces that we need. That someone's has the right BMI, they've had the proper sleep study. So let's assume that one of the folks that are listening now is interested and they want to go on to the next step. The next step would be to make an appointment. I would assume you'd get an appointment within about a week. We'd have to make arrangements for the sedated endoscopy, and we would get that pre-authorized with your insurance. I've seen 0 problems with that. And then after that, you're sedated that day minimally. But what I typically do is call folks later that day or on a Saturday, because I often do surgeries on a Friday. And we talk about what it looked like. And then for most of the insurances we've had, assuming that all the pieces are in place and patients are appropriate candidates and they're interested in proceeding, it takes 2 to 4 weeks from that time for your insurance to approve it. We've had some very quick turnarounds. Medicare, basically, if you are qualified, you're qualified. I mean, we don't have to get any approval. But we don't want to be doing it on patients that don't need it, but we go through the proper steps, and Inspire helps us with that. Other patients with Blue Cross Blue Shield of Wyoming, of course, because no one else had done this in Wyoming, I was the first person to submit a patient for approval, and that took a couple of weeks. So I would say it's patient specific and insurance company specific, and it may change towards the end of the year and related to some of the coronavirus slowdowns. But in my experience, the quickest we could move from start to implant, like if you called tomorrow, I would think would be like 4 to 6 weeks realistically.
Thank you, Dr. Trott. I've got 5 more questions as of right now. Next question is, if it does not work for me, can it be turned off or ultimately removed?
Yes, it can. Well, basically it's off during the day anyway, so it could sit there and never create a problem. And if for some reason someone, actually my patient last week, I did one of these Friday, just 5 days ago, and he asked me, am I going to become dependent on this? If it doesn't work, or if the battery runs out in 11 years and I don't rush right in to get a new battery, am I going to be dependent on it and my body won't be able to work without it? You'll just go back to having sleep apnea that you had before. So it can be removed if necessary.
Great. I have another question, and I can answer this one. What areas of the body cannot have an MRI? And right now it's just the torso. So Dr. Trott mentioned it. It's basically shoulder to shoulder, hip to hip. So we have MRI compatibility with the head and neck MRI coil and the extremity coils. So wrist, elbows, knees, ankles, anywhere on the arms or legs, right up until the shoulder. But right now from hip to hip and shoulder to shoulder, the torso does not have MRI compatibility, but we expect to get MRI compatibility in the next probably 18 to 24 months. Next question, is there an upper age limit for people in their upper 80s or lower 90s?
I'll answer that also. There isn't one. I think it has to be a discussion that we all have about what's the realistic reason we're doing the operation? I mean, I ask this of everybody, whether we're doing ear tubes in the kid or a nose operation with someone with nasal obstruction. I have had patients in their mid to late 80s that are totally appropriate candidates, have really thought through the reasons and why they're not having success with what they're currently doing, and that would be reasonable. Seems kind of crazy to me, who's someone who, is 85 and has tolerated CPAP for 30 years. I mean, they tolerate CPAP, so why would you switch them? So my goal is actually to minimize the number of operations that we do and then make the operations that we have a success. But the punchline is there is no upper age limit, but we need to be realistic about what we're trying to accomplish.
Next question, why is someone that is overweight, why can someone overweight not get the procedure? Why is there an upper BMI limit?
Haven, you want to tackle that?
Yeah, and I guess weigh in, because you're the one that does the endoscopy. But
yeah, I mean,
it's the circumferential addition of tissue to the neck with typical weight gain, where you've got to have the right anatomy, that by tongue protrusion caused by the device to benefit from the device. So in other words, if it's just someone who weighs 500 pounds or what have you, and there's just so much tissue just surrounding the whole airway, then it's not going to make a difference if you protrude the tongue, because essentially the other areas will just cave in around it and you'll still have apnea. I mean, that's the basic, I think that's in a nutshell. And so when you don't have that much weight, then the true anatomy is there, and some people's airways are different than others. It's not always weight related to cause airway that will versus won't benefit from the device. So that's why they have Dr. Trott just take a look and do the endoscopy procedure. But that's the reason why like morbid obesity is not in the inclusion criteria. You can be overweight, I think the technical definition of overweight is a BMI of 28. And so you can still be, by medical definition, overweight and still get this device. You just can't be morbidly obese.
And when it first came out, I mean, there was a push to try to do this on people with much lower body mass index. And, it crept up from 28 to 30 to 32 and now 35 for Medicare. I don't think it's going to go up any higher. I mean, what we want to make sure of is that we're not doing operations on people that are going to partially benefit. I mean, the only reason from my perspective does someone partially benefit if someone's got such hellacious sleep apnea that their apnea hypopnea index is like 60 or 70, and we probably can't cure them, but they can't tolerate CPAP, and we can make them so much better that it'd be a life-altering decision to do it, even knowing that we wouldn't cure them. That would make sense. But we don't want to be doing operations that are partially effective when there are better solutions. And occasionally, I actually have one patient who is elected for bariatric surgery in that very high BMI group. And that's probably a better solution.
All right, and then last question of the evening, is Parkinson's disease a complicating factor?
I've not had that question asked. I would assume that'd be a relative contraindication. We'd have to discuss, again, the pros, the cons, and the whys, from my perspective anyway, as a surgeon. I mean, surgically, absolutely not. I mean, the devices, it's a technical procedure. What I would have to do, I mean, I would actually ask other people that potentially have had folks with Parkinson's. It's a neuromuscular disorder. It's a pretty complicated question, so we want to get opinions from neurologists, and I'd be interested in what Dr. Malish has to say about that.
Well, I guess I need to understand in what sense would it be a contraindication? So in other words, from the disease itself, from having Parkinson's, I don't know of any contraindication per se of getting the device, because if you've got obstructive sleep apnea and happen to have Parkinson's, then there shouldn't be a reason that you shouldn't be able to get the device. There are some complicating issues, though, that some people with Parkinson's have neurostimulators, and I would double check to see if there's any compatibility issues with like a nerve stimulator for the Parkinson's being in place at the same time as the Inspire device stimulator.
And there are other devices. I mean, we have patients that have, for instance, pacemakers or defibrillators for basically cardiac devices, and they are compatible. But there's an entire team at Inspire that helps us vet those questions, so that we certainly don't want to be putting in something that's going to not be compatible with another device.
And I will say that the Parkinson's patients, sometimes there's some subtleties to their obstructive sleep apnea where they may benefit from the positive airway pressure per se. There's some abnormalities with vocal cord motion during sleep where they might need the positive airway pressure to literally push the vocal cords apart in some types of conditions. So it really depends on what the detail of their sleep study showed too.
Thank you both. And I can also chime in and let everyone know that Parkinson's is not an FDA labeled contraindication, but those were great answers. And to Dr. Malish's point, we do make an effort to keep the stimulators apart by at least 6 inches if we're going to implant Inspire. So with that being said, thank you guys for being on the call tonight. Dr. Trott, Dr. Malish, and Shauna, thank you for your insight and your presentation on Inspire. If there are any questions, you can continue to email your questions and we'll make sure we get those answers to you. To schedule an appointment, you can call the number on the screen or go to the website. Thank you all for being on tonight. And again, Dr. Trott, Dr. Malish, and Shauna, thank you guys for your presentation. Have a wonderful evening.
Thanks.
Thanks.